Thank you for this opportunity. This study has been prepared with help from many people, inspired and co-researched by health consumers and the support of MECFS South Australia and MECFS Australia. I want to begin this presentation with a story. It needs of your imagination. Imagine living in an eternal COVID-19 lockdown, feeling alone and socially isolated, but not because of the virus, but because of other mobility or health issues. Your social circle diminishes. You have fewer visitors, if any. Your health deteriorates, and you cannot do your own things. No food shopping, no visits to the doctor, no meal preparations, not even going to the toilet by yourself. This is a real state, a real situation for many people, and it can happen to any one of us. It can happen to you, it can happen to me. Being homebound, being trapped, unable to leave your home without the help of someone else. You can be homebound without being a person with disability, because living with disability and being homebound are not considered synonymous. However, 1/3 of people living with disability are profoundly affected by it. This implies that more than 1.4 million Australians can be homebound because of disability and because of many other health reasons. Many of those reasons are obscure for health practitioners and therefore leave homebound people outside support programs. Eventually, friends, family, medical and social services can become skeptical and often uncaring. Frail, homebound, and bedridden people simply fall off the radar of everybody. They require extraordinary efforts to do what any of us, consider a simple task. Over the years, carers, parents leave, die, or become ill too. This situation leaves homebound people totally alone. They become invisible. Without help, energy, and increasing dysfunction, everything becomes hard to access. Even basic GP medical care is unreachable because of their physical attendance requirements. They are persons, just like you, just like me, like your family member, of your friends. Anyone can have a change in circumstances and so become frail, homebound, or bedridden. These Australians are misunderstood and marginalized. But it doesn't have to be this way. They should have social and health inclusion programs. Like any one of us, they need care, they need love, support. They do not want to stay trapped. They have dreams, passions, and aspirations. Before their illnesses, many of them were active members of our communities. They were working as entrepreneurs, as doctors, musicians, defense personnel, dancers, students, and so on. They had a positive change recently. Here an explanation. In the past, clinicians only met clients when the person was well enough to attend an appointment. With the introduction of telehealth for GP services, we could meet with them. Our symptoms were when our symptoms were too severe to allow us to leave home. The understanding of our illnesses, severity, and the nature of our impairments was dramatically improved. This is Ms. Penelope McMillan, a co-author of this study and a chair of MECFS as Australia. She lived with myalgic encephalomyelitis, chronic fatigue syndrome, a disease that unfortunately is turning many Australians into frail, homebound, and bedridden people. However, on the 20th of July, after that positive change, without consideration of consumer feedback or needs, access to GP via telehealth services was terminated for people who had not attended a face-to-face appointment in the last 12 months. During that time, we, homebound people and health researchers, were culminating an Australian survey targeting homebound people and their family, carers and friends, their affiliates, via social media across different platforms and consumers advocate groups connected to disability, chronic diseases, and affiliated issues. We asked them about the actions that were important and needed to help them. The objectives of our study were to provide evidence to inform decision-making, health practice, and health research about the issues of frail, homebound, and bedridden people, and to explore consumer-centric solutions that address their social isolation, marginalization, and other needs. Our data collection occurred when the first wave of COVID-19 was departing in about July and the end of July. 27% of our responders were identified as homebound and 73% were their affiliates. These were the important and needed action for the 27% of our respondents, homebound people. So they asked for delivering education for all health professionals and services providers about people with their needs, educating Centrelink, NDIS, and government services about paperwork difficulties, for example, providing more time or accepting GP reports rather than specialist paperwork only. Gaining access to community care, for example, NDIS, aged care packages. Receiving adequate Medicare rebates for home visits. And importantly, extending the existing telehealth telephone consultation for rural and remote patients to allow to cover patients who are housebound or bedridden in metropolitan locations. Remember that these services, when they were accessible to everyone, they were cut just to people who could attend face-to-face appointment within the last year. We also did a rapid scoping review with the aim of identifying existing interventions enhanced by technology that target social isolation for older adults. This population was chosen because they and the frail, homebound, and bedridden people face similar circumstances. Our literature review indicated that to mitigate and prevent loneliness, social isolation, and health marginalization of frail, homebound, and bedridden people in Australia, current practices and knowledge can be effectively operationalized via digital and similar technologies, for example, using wearable sensors, system mapping, social media, and robots for virtual connection, distant monitoring, and virtual care. This investigation helps us all to conclude that our task is not only implementing these technological solutions, but educating several service providers and policymakers about the devastating consequences of maintaining a healthcare system working around the exclusory and impractical requirement of physical attendance. Help us change this situation. Together we can do it. We are welcoming partners for escalating this study through health and social scientific publications, epidemiological publications to understand this group further, artistic campaigns and grant applications concerning the implementation of technology, virtual care, social prescription solutions for this population. We are looking forward to hearing from you. Thank you for this opportunity.